Totally irrational, terrible anxiety, and just could not sleep. I could not remember anything.
Maybe they feel like their body's failing them and they're having these mood changes, these, chronic fatigue or exhaustion or weight gain.
That suddenly I was like, wait a minute, what about menopause?
Welcome back to the Female Blueprint podcast. Today's guest is Dr. Noor, a board-certified family physician and menopause specialist who is redefining midlife wellness. It wasn't until she experienced perimenopause herself, debilitating fatigue, brain fog, and way more, that she realized how little she knew about menopause care. Despite being a seasoned physician, she found herself dismissed and misdiagnosed herself, which led her to find Lifestyles by Noor in New Hampshire. Now she's on a mission to empower women and men in midlife with personalized, evidence-based care that goes beyond just hormones. Dr. Noor, welcome to the Female Blueprint podcast. I'm so excited to dig into this conversation and challenge some of the myths that women are told about midlife health.
Thank you for having me. I'm thrilled to be here. And it's Menopause Awareness Month, so it's perfect timing.
Perfect timing. Oh my gosh. Well, I'm so excited to dive into this topic. You're actually my first guest, as we were just discussing on the podcast, talking about midlife health. So I'm ready to go all in. And let's just kind of start with, your story. I think so many women that might be listening right now may be feeling dismissed in this time of their life, struggling with like fatigue and brain fog and like weight changes and just being told, it's normal. So would you mind sharing briefly like your story and kind of how you got into this niche?
Yeah. So I would call myself very high functioning always. My husband will tell you that, there isn't a test that Noor can't ace. I took every exam, anything I did, top notch. I felt like I could do anything and my brain could do anything I wanted it to do. And I that was my power. And we, had a lot of movement in our life and career changes. And we moved to the US and, I was about 38 years old and it was around COVID as well, which kind of clouded it for me. And COVID, the start of COVID was really stressful. I was a healthcare provider in a primary care setting and you just sort of didn't know what was going to happen next. It was quite scary. And I started to have terrible anxiety, brain fog, intrusive thoughts, and I just couldn't sleep. I could fall asleep, but then I would be awake and I would wake up and my heart would be racing and I would have these intrusive thoughts like, the kids were going to get run over or the house is going to burn down or, somebody was dead. It was just really scary, intrusive thoughts. And I would get up and I would be like checking on the kids and, like going in the basement, just acting like
Rational.
A crazy person, irrational, and I would be obsessed with sounds. Like I would hear, the boiler coming on in the basement and I would like jump out of my skin at 3 a.m. thinking, oh my God, somebody's in the house. Just totally irrational, terrible anxiety, and just could not sleep. And as somebody who's always, been able to, I could remember anything. I could recall what you were wearing on, Tuesday, August 2nd, whatever it was. I mean, a memory and a photographic memory. I could not remember anything. I'm like, my brain stopped working. I was turning up places at the wrong time, in the wrong place. I was bringing my kids to the wrong place at the wrong time. It was really embarrassing. Like, what has happened to my brain? And I thought it was long COVID. Initially I was like, this is long COVID. Then I, was seeing doctors and then there was, bandying around this idea of maybe it's MS and and then I ended up, kind of seeing a psychiatrist and they were treating me for anxiety. I just didn't get better. I just seemed to just get worse and worse. And I just was not able to function effectively in my life. And then was kind of a middle of the night moment. I had one of these wake ups and I had a night sweat. And I was like really sweaty. And it was just this one thought that suddenly I was like, wait a minute, what about menopause? And my mother went through menopause early. She went through menopause in her early 40s. So, and it just, when I suddenly had that realization, number one, I stopped feeling crazy because I think I figured out what's wrong with me. But also I realized that I don't know anything about menopause. I mean, I've been caring for older adults for my entire career. And I knew nothing about menopause. And the more I learned, the more I realized I didn't know. And that just kind of sent me down this rabbit hole and journey of trying to understand all the things I didn't know. And I read, I mean, if here's a book plug, if there's anything to read Estrogen Matters by Avram Blooming and Carol Tavares. That's the first place to start if you want to learn about menopause and perimenopause and just about hormones. It is an excellent book. So I read that, and then I went to the conferences and I met all the people and took the test, and it opened my eyes to a complete area of medicine that I just didn't know about. I wasn't taught, or it just was kind of glossed over. And I realized, and then I couldn't get help. When I realized it was my hormones, I couldn't get anybody to help me. They were like, "You're 38. What are you talking about? Go away. You're fine.
Yeah,
Have the
you're
pill.
still
Take the pill.
childbearing.
You're good." And, and I had regular periods. I still have regular periods.
Wow.
And I finally actually used my alloy online. I could have prescribed for myself, but I just didn't, like, at the time, feel like I knew what I was doing. So, and they prescribed for me, and it was immediate. When I say I was sleeping within 48 hours, I was sleeping within 48 hours of starting hormone therapy. It was immediate. And then I was like, I got to get this to other women, because other women are being gaslit. They're being told, eat less and work out more. And I don't know, take ashwagandha and you're just not lifting heavy enough. And, all of those things are reasonable things to discuss. But at the crux of it is a hormonal deficiency that if you're presenting with symptoms, the only way to treat effectively is to replace those hormones.
Yeah. So for you, what did you find specifically that was like lacking? Like what was the start of it, and like what did you get prescribed, and what
Yeah.
what was that like?
So I was prescribed Eva Mist, which is an aerosolized estradiol, and micronized progesterone, or Prometrium, but micronized progesterone, 200 milligrams to take at bedtime. So I often show this on Instagram, but I use the spray. And so I started with one spray and 200 milligrams of progesterone, and it was life-changing.
Like night and day.
Mm-hmm.
Did you ever figure out or look into like how was this happening? Like how did you start having that deficiency? Was it, from having kids, or like, where did that start?
I think I started in, perimenopause. And if you really understand, what menopause and and we can talk about this in great detail if we
Yeah.
want, but what actual perimenopause and menopause are, when you really understand what it is, you can understand why the changes start happening. Right. So if you look up the word menopause, menopause is defined as the point in time at which you're a year without a period. That is the medical definition of menopause, which is really problematic. It's a terrible definition. It does not speak to the experience of women who start having symptoms like 10, potentially 12 years before their last period. Number one. Number two, it makes it about periods, and periods are a symptom. Like, periods are not a real great indication of what's undergoing physiologically in your body. Also, what about all the women that don't have periods, that have had an ablation or have a Mirena IUD or have had a hysterectomy? Are they in menopause? What is going on there?
Bad
So
definition.
I like to redefine menopause when I'm talking to my patients and whenever I'm speaking, because if we redefine menopause correctly as what it is, then we can understand what's happening in perimenopause and what we do, how we treat it. So I like to redefine menopause as the point in time at which we run out of eggs, right? So males and females are fundamentally different in their gonads. Me and you have ovaries, males have testes. In a male testicle, right at this moment, they have a form of stem cell called a germ cell. So they can make fresh new sperm every day from now until the day they die, unless they're castrated. We don't have that ability. We made all of our eggs in one big show of industry when we were a 20-week-old fetus in our mother's uterus. And what we made was our lot for life.
Wow.
We have no capacity after that point in time to make any more, because the stem cells go away. So it's a numbers game, right?
Yes.
And what happens is, so we estimate at 20 weeks gestation, we have somewhere in the region of 6 to 7 million eggs. By the time we're born, just because of what we call cell death or atresia, we're down to 1 to 2 million eggs. By the time we go through menarche, which is our first ever period, we're down to 500,000 eggs. And then you start to cycle. And when you cycle, you don't just use one egg. You use hundreds of eggs to get that one egg out. Additionally, in the background, you have this ongoing atresia. So by the time you're 40, you're down to less than 3%. And then it's a slow coast to zero.
Mm.
Menopause is when you've completely run out of eggs. Menopause is when you're running out of eggs. So when you've dipped
Wow.
below a threshold where you can't bring those hundreds of eggs with you every time in a menstrual cycle. So you're not
Mm.
making the hormones the way that you used to, and the whole thing goes oury, right?
That's probably
So if
the
you,
best definition I've ever heard.
it makes sense, right? And
Yes.
if you can understand that when we make estradiol and progesterone in our ovaries, those are made by eggs. So estradiol in our ovaries is made by our follicles. So it's made by the eggs that are developing in our menstrual cycle. Then we ovulate, and that ovulated follicle that's left over kind of looks like a deflated balloon. That then makes progesterone, and that makes progesterone through the second half of our cycle. Now, if in menopause you don't have any more follicles, guess what? You're not going to make any more estrogen or progesterone.
Mm.
Do we agree on that statement?
Yeah.
In perimenopause, you're running out. So now, whereas maybe when you were 20 and you started a menstrual cycle, you started to develop 200 follicles. Now you're in perimenopause and you've dipped below the critical threshold. So your ovaries now only able to make 10 or 12
Mm.
follicles. So you're making less estrogen. And your
Wow.
brain sort of panics because it knows you're not making enough estrogen. So it tries to get your ovary to do more. And your
Yeah.
ovary then panics and starts to look for more follicles. So you end up in this situation in our ovaries in perimenopause where we have multiple follicles kind of all in different stages of development. Everything is out of sync. It's a
Mm.
total mess. So in perimenopause, what you see is you'll see an estrogen that's suddenly high and then suddenly low and then suddenly high and then suddenly low. It's just all over the place. And then you come to the middle of the cycle and your brain is like, I guess we'll try to ovulate, but it's
Yeah.
just a mess. There's nothing to ovulate. So nobody makes progesterone. So perimenopause is characterized by having not enough eggs. So you're getting some eggs going, but not enough. So you get this very labile estrogen level and a very low progesterone level. So it's
Interesting.
biology, right?
Yeah.
It's just biology that you've run out of, you've dipped below a threshold of a number of eggs that you have left. And
Wow.
so you're presenting with these hormonal symptoms.
So is there anything that like can kind of jumpstart this like perimenopausal process for women, like uh environmental factors or like trauma or like anything that can like shoot them into it faster, or is it like purely genetic like you're saying, like sometimes family?
So there are factors that will speed up that cell atresia. So that loss
Mm.
of eggs, there are factors that will speed that up. And a lot of them are lifestyle factors, toxin exposures, especially things like chemotherapy can really
Mm.
affect the rate of loss of your eggs. And then some of it's genetic. So it's a combination of things. There's lifestyle factors, exposure factors, and then genetic factors that all kind of are interlaced, if you like. I also find
Yeah.
that women that have kids late, like 37, 38, 39, 40, a lot of them seem to go from postpartum really directly into presenting with perimenopause.
Oh, wow. Okay. So have the kids early. I'm
Well,
31 and I haven't had kids yet. And I'm like, oh my gosh, the clock is ticking.
that's a really big conversation and question. I mean, it's yeah.
Yeah. Well, let's get into it. I mean, honestly, I have a couple questions I definitely want to
Yeah,
ask you, but I'm like, here we are. This is me. This is my life. So
yeah,
31 years old, and I'm like, oh my gosh, time is clicking. But I see I've treated women, honestly, in their 45, 47, and they've had kids.
yeah.
So I know it's
And you still
possible.
in
Yeah.
perimenopause, you still might ovulate.
Yeah.
Think of Father of the Bride too, right?
Right.
When she was pregnant, they were both
Yeah.
pregnant at the same time. That's a
Yeah.
thing, right? And
Yeah.
often women will not realize that they're ovulating because they don't ovulate every cycle, in perimenopause. So they'll
Yeah.
sometimes ovulate. So it's pretty hard to predict,
Mm-hmm.
when what's going on. So
Right.
yes, you can get, and that's a conversation that we have a lot, when we're
Yeah.
treating perimenopausal women is, do you
Yeah.
need contraception, right? Because
Oh.
whether you need contraception is going to guide what we plan to do for treatment.
Yeah, if
Because
you're
we
giving
don't,
them hormones, right?
yeah. So, one way of treating a perimenopausal female is you could give her birth control, perfectly reasonable, if it works for her. And that's a totally reasonable thing to do. Other option would be to combine like a form of hormone therapy with a different form of contraception, like an IUD, for example. I love IUDs in the perimenopausal female because often what we see in perimenopause and menopause is a lot of times their periods get heavier and a lot less manageable. So using an IUD can be a really great way of just quieting those periods so they don't get crazy, but at the same time, giving them some contraception. And then once you've got that under control, you can give them estrogen to manage their symptoms and not worry kind of about the uterus at all.
And worrying about getting pregnant at like 48 or 49.
Exactly. It happens.
Absolutely. So what does that look like for somebody who is going into, like, is perimenopause not necessarily, like, I don't want to say it's bad because it's not bad, it's natural, but like you say some people are in it for 10 years, like what's a normal length of time that someone should maybe anticipate, or like what's optimal for perimenopause? How long should that be?
So there is no optimal. Everybody's an individual. Women can be just sailing and feeling awesome. And then suddenly, they have 6 months of symptoms of perimenopause and then don't have a period. And they're in menopause and are symptomatic. And then you have others that are very, very symptomatic for a longer period of time. And I'm sure that there are other factors involved. There's a lot of discussion around, for example, women with mast cell activation, with women with fibromyalgia, women with ADD, they seem to present with worse symptoms as their hormones change. So I'm sure that there are other factors involved that make some women more sensitive to the changes, whereas others maybe don't feel it as much.
Interesting. Okay. So for someone like me who's 31, like obviously the clock is ticking, and I probably, in the next year, God willing, have kids, but you're saying, if I space it out, like if I want 4 kids, for example, I might be 36, 7, 8 by that time. So you're saying it could almost catapult you depending on lifestyle and factors
Some
and stuff.
lifestyle factors. Yeah. Some people in late, that have kids later, you tend to see that they then start to kind of, peak into perimenopause straight out after postpartum. But if there was anything, it all comes back to lifestyle, right? To eating well and exercising and avoiding toxins. Those are all things that are going to improve your rate of fertility and keep you well for longer. Even if you present with perimenopausal symptoms, even if you have perimenopausal symptoms, yes, if you are having debilitating symptoms, really hormones are the only thing that's going to fix that. But if you go into that and you're well and you're fit and you're eating well and you have great bone density and you have great muscle mass, all of that's going to work in your favor.
Absolutely. Okay. I love that. That's good advice. So what type of so say a woman's coming to you maybe in her 40s and she's feeling all of these symptoms, she's been dismissed by another provider. So what makes your practice a little bit different than like traditional medicine where some doctors are just like, "Yep, you're going into perimenopause. Here's this cream," or I always see like estrogen creams as like one of the first prescriptions, right? How is the way you practice a little bit different than like I guess traditional?
Yeah. So what we do, first of all, is we spend a lot of time with patients. So, we take really a full history. We try to get an idea of everything that's happened before now, what the situation is, what their goals are, because sometimes you can listen to somebody and you can think that their goals are, I don't know, weight loss. And then they're like, actually, no, it's actually my libido. I really want to have, intimacy with my partner. And, so really gleaning those goals, getting to know a family history. So we spend a lot of time just kind of getting to know the patient, getting a full history. I also have a DEXA scanner in our office. So we do, bone density and body analysis. And you'd be very surprised how many young women have terrible bone density.
Wow.
And, they would never know that because we don't screen until they're 60 or 65. And it's really just too late at that point. We also do a very in-depth lab panel. So we look, in addition to all their hormones, we're looking at their metabolic parameters, their insulin resistance, their inflammatory markers, thyroid, any nutritional deficiencies, just to kind of build a picture, because it's really important that we don't attribute something to perimenopause that's something else, right? So, for example, I saw a patient today, and when she first came and saw me, she had debilitating fatigue, and she is perimenopausal, but she had a ferritin of like 6, right? Her iron was super low. We need to fix that problem. Yes, we needed to address her hormones, but there were
But other
multiple
things as
things at
well.
work, so it's important when we're
Yeah.
dealing with patients that we don't just, only address hormones and then walk out the door. There's often multiple things at work. And then we have
Yeah,
a dietitian
absolutely.
on staff that sees all my patients. So they have dietetics involvement. And I have a mind body therapist that sees my patients as well. So she's a meditation, mindfulness, life coach, which all of us need, especially around things like
Absolutely.
sleep and relationships. So we offer kind of a more, it's really trying to hit every aspect of your life that could be playing a role and a factor in how you're feeling to make sure we don't miss anything.
Yeah, absolutely. So many women start to feel too like when they are dismissed or they are starting to show symptoms, maybe it is early for you, like 38, and maybe they feel like their body's failing them. Like why, and they're having these mood changes, this, chronic fatigue or exhaustion or weight gain or whatever. Why do you think that is? Like, why are they feeling like, oh my gosh, my body's failing me so young? Obviously, there's a lot of things at play, right? But
There's a lot of
what is
things
your
at
take
play.
on that?
There's a lot of gender bias there. There's a lot of what we expect, as women of ourselves. We expect ourselves to be everything for our family, to do everything perfectly, to be great at work and great at home and a great, daughter and a great sister and a great brother and a great stepmother and whatever it is, right? There's a high expectation of ourselves, and when we start to kind of wobble and start to have difficulty managing all of that, we view it as a failure because that's how we've built society, and that this is your job and you have to do everything.
And I think that sometimes too, that expectation and that perfectionist mindset, we put so much more pressure on ourselves that then can make us more ill or, not as
100%.
optimal as what we should. That
100%. I
like
mean,
chronic stress.
there's, the chronic stress, but also chronic expectation. We know that chronic stress and expectation, is going to have an impact on your stress hormone levels, which is going to have an impact on your blood sugar, which is going to have impact on your weight, on your sleep. And we know that, increased stress is associated in women with increased risk of autoimmune disease. There are biological changes that happen when we are under stress that have a long-term effect on our biology. And I
Mm-hmm.
think we sometimes fail to make that connection. And
Mm-hmm.
that's one of the reasons that I have a mind body therapist in my office, because I
So
want you to
important.
learn meditation. I want you to learn how to sleep. I want you to learn how to manage your thoughts, because one of the issues is that, you can fix everything else, but if you're so anxious and all in your head and can't calm down, then nothing I can do can help you,
Yes. Yes.
you
I
know?
don't think anybody talks about that enough. No other MD like in traditional settings will talk about that. They're not asking those questions. They're not talking about sleep and stress and nutrition, and having that on your staff is so
Mm-hmm.
paramount for somebody in a
Yeah.
midlife crisis, if you will.
Yeah.
Like they need to
And
focus
people
on so
think,
many
when I
things.
say to people, I really want you to see my, my meditation specialist. A lot of people will, they'll roll their eyes and be like,
Yeah.
for goodness sake, I go to
Oh, she's
yoga. What are you
woo-woo. She's one
talking
of
about?
those.
Yeah. And one of the things that I like to show people and talk about and is I use continuous glucose monitors a lot on my patients. And so we review that a lot. And often I will show them and they'll be like, I was like, what happened here? There was a spike here. What happened here? Oh, I had a fight with my husband. I was like, do you see how
Mm,
there's an immediate biological impact of you being stressed? Right?
mm,
Having high blood sugar is like shards of glass in your bloodstream, right? And
yeah.
you having a fight with your husband and not able to calm yourself down has resulted in a spike in your blood sugar, which has
Wow.
detrimental effects on your biology. It's not woo woo, it's
No.
biology.
That's so good. I
Yeah.
don't think a lot of like I don't I mean, I know that like yes, I get stressed if I have an argument or something, but when you can see the data like that, that helps people really understand like oh,
Mm-hmm.
she's not out in left field. She's
Yeah.
actually this is real.
And I think that's something that's nice. I'm not a huge fan of like, the whoops and the aura ring. I think people can get very obsessed with these things. So I like to kind of use that, take that with a little bit of grain of salt. But people will often see that as well. Your blood pressure starts to rise, your heart rate starts to rise, your temperature changes when you're
Yeah,
stressed, right? Your
absolutely.
body is having a biological response.
The nervous system. So you're
Hmm.
doing nervous system healing. I love
Yeah.
that, right?
It's all part of the whole picture, right?
Yeah. Absolutely. So a question I'm sure you get all the time.
Mhm.
So how old is too old and how young is too young for hormone replacement therapy?
So where do we even start with this picture? I'm just going to turn on this light. So I would say one of the things that comes up, this comes up in my office every day, in my DMs, anytime I get interviewed, how old, what is too young and what is too old. So the first thing I will say is, in my opinion, there is no too old. Too old is not a thing. This idea of having this sort of 10-year window came from the Women's Health Initiative. We could talk about that, but it was that study that was done in the early 2000s, and part of the outcome of that was that they showed that the earlier you start hormone therapy, the better, basically. Right.
Mm,
So they said that if you initiate hormone therapy within 10 years of menopause, you decrease a woman's risk of heart disease by whatever it is, 30%. And so this gave this idea that, oh, after 10 years, you can't start hormone therapy. No, all we said was that the preventative benefit is better if you start it sooner.
earlier.
Even if we were to put cardiovascular disease to one side, you're still going to get benefit for your bones. You're still going to get benefit for your genitourinary system. You're still going to get benefit for your muscles and for your brain and for your mood and for your sleep. So there's no expiry date on when you use hormone therapy. And I start women in their 70s. I had a woman in her early 80s that I started on hormone therapy. With
Wow.
regards to how young, this comes from this idea that if you're too, perimenopause starts right before menopause, which it doesn't. So if you think, the average woman in the United States will go through menopause at age 51, and perimenopause can 51, but the actual span is 45 to 55. And a woman can start perimenopausal symptoms 10 to 12 years before she goes through menopause. So for your 45-year-old that goes through menopause when she's 45, that means she could start perimenopausal symptoms when she's 32,
Wow.
right? Most women aren't too young. But I add the caveat that we have a tendency to park, the need for hormone therapy with the perimenopausal and menopausal woman. And I just
Mm,
disagree with that. We have many younger women who have not menopausal, hormonal symptoms, PCOS, PMDD, PMS. And they, at the moment, the only blunt instrument that they're given is birth control. They're not offered
mhm.
anything else. Whereas
Yeah.
I do really well with my patients. I give them bioidentical hormones. And guess
Mhm.
what? They feel amazing, right?
Yeah.
So this idea that it's owned by menopause and perimenopause is incorrect. Women that are younger have hormonal problems, and we can treat them very effectively with bioidentical hormones.
Wow. So I bring this up too, and I'm sure it's a question you got asked all the time, but it was something that I'm curious about because my testosterone was so low, like maybe like 6 to 8 months ago, and one of my providers was like, "Well, I don't want to give it to you yet because you haven't had kids yet, and I worry about giving you like testosterone pellets." I'm sure there's other forms, maybe like topicals and stuff, but she mentioned that and I was like, "Oh, okay." And I just like took her word for it, right? So like is that what is your take on that?
So the question about testosterone and replacing testosterone really depends on what we're trying to achieve, right? So are you symptomatic? So
Mhm.
if I have a patient, for example, and she's really struggling with low libido, or if I have a patient and she's really struggling with, difficulty with her energy or brain fog or fatigue, then I would consider adding, consider whether testosterone would be helpful if testosterone is low. The issue becomes when you start to give someone testosterone, if they want to conceive, that's not going to mess with your rhythm, but there is what we call a negative feedback loop. So remember how I said, like, your brain is talking to your ovaries and your ovaries are talking to your brain.
Mhm.
When you introduce something like testosterone, you could impact that, the way that it's talking to each other, right? So
Yes.
you could reduce maybe how much LH or FSH is being made by your pituitary, potentially maybe disrupting some of the normal kind of ovulatory cycles. But that can be watched, right? They can
Right.
keep an eye on your luteinizing hormone and all your other hormones to make sure that everything still looks normal and you're still having periods, and they can do ultrasound. There's things that can be done. And also, I don't favor pellets. If I was going to replace testosterone in a young woman, I would probably do something topical and at low dose to start, and then very, very, sort of creep the dose depending on the response. Right. The problem with pellets is that once they're in, you can't take them out. And so you're kind of stuck. So if you have a bad reaction, you have to ride your bad reaction because there's no way to remove it. Whereas if you're doing something topical, you just stop doing it. Right. So you did it today and you stop doing it tomorrow. And the other thing is with pellets, we tend to find kind of a significant increase in your estradiol or testosterone level initially, and then it sort of slowly wanes, and then they get another pellet and then up and down. So you're not getting a very great steady state overall.
Okay.
It works for some people. Some people, pellets are the best thing, and that's not wrong. It's just not my favorite approach, especially at the outset.
Yeah, absolutely. Well, thanks for clarifying that, because I'm curious, people talk about it, you're on it too young, but like, why is your testosterone so low? Like, how can you fix it otherwise versus just getting on like pellets or like a topical or something like that? So that's really
And that comes back to, when you think about, why are your hormones why are some of your hormones so low? Somebody needs to figure that out. Is that like a PMDD picture? Is that a PCOS picture that your, testosterone's high and your estradiol's low? I think there needs to be a little bit, more digging just to make sure we're not missing any big diagnosis here that needs to be figured out in the meantime, right? So it's important that we don't just paper over cracks, especially in a younger female, that we figure out, why is this happening? What are the goals? What's the underlying mechanism that's causing this? And how can we manage it better?
I love that. That's a good way to put it. Like, there's so many things that you need to be able to look at and paint the picture bigger, because you can't just focus on like small little details and just give them like a pill or like a cream or whatever to just be the solution to it all.
Exactly.
Another question would be like, so what's the emotional impact on women who are hesitant to start HRT? Maybe they've heard good things, there's bad things, maybe there's risks to it, or they're told, oh, you don't need it yet, and then another provider's like, oh, you need it. Like, how do you kind of like help women make the decision of like, no, I think this is actually the best option for you?
So one of the first things that we do, you can't really make decisions for yourself unless you understand. And women are great at making decisions for themselves, and they make great decisions for themselves if you give them the tools to understand their own biology, understand the potential outcomes, understand the repercussions of doing something versus not doing something. They can make great decisions for themselves, and they can be their own advocate. So what we do first is we do some biology lesson. We talk about, like we just did, right? What is happening in our body? What's happening to our eggs? Why are we not ovulating? Why are we not making our hormones? And so that they understand where they are biologically. And then we talk about why people would take hormone therapy. And there's basically overall two reasons why women take hormone therapy. The first one is symptom management, right? So I have hot flashes and I can't sleep, and I have brain fog and I have mood disturbance and I'm anxious. I have palpitations. I have joint pain. There's hundreds of potential symptoms of menopause and perimenopause. That's one reason. I have debilitating symptoms. They're really interrupting my life and I need to do something about them. That's one reason. The second reason is prevention. For example, I have a really, really strong family history of osteoporosis in my family, and I am not going to let that happen to myself, right? So 1 in 2 women will have an osteoporotic fracture in her lifetime. I just think that is an unacceptable statistic.
Crazy.
And I take hormone therapy for one of the reasons to prevent osteoporosis. And that's a perfectly reasonable reason to take hormone therapy should you choose to. So we need to lay down the groundwork biologically, decide if you fall into either of those buckets or both. And then if you do, we treat. And if you think, actually, I don't really have that many symptoms, I'm not feeling, I've managed them whatever way. I'm exercising regularly. I feel good. My muscle mass is good. And I don't really want to, take hormone therapy. That's also fine. I'm not here to tell you every woman should take hormone therapy. What we're talking about is that every woman should have the option of hormone therapy should she choose to.
Absolutely. So are there different types of hormone therapies? Because I know that there's bioidenticals, and I think there's other forms, but people are like, oh, I'm not doing that. I just want to do the bioidentical. Can you explain like what it looks like and why someone would maybe want one versus the other?
So the first thing we need to understand is that when we talk about hormones or hormone therapy, we're really talking about many, 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 many products, hundreds of products. And birth control falls into the bucket, in my opinion, of hormone therapy. It's a form of hormones.
Mm-hmm.
Do we agree?
Mm-hmm.
So first of all, we split it up in two. We split it up in what is not the same as we make in our body, right? And what is the same as we make in our body. So when people use the term bioidentical hormones, sometimes it's a little bit hijacked to talk about things that come from a compounding pharmacy. And that's just a marketing term. When we talk about bioidentical hormones, we're saying that the hormones that we're taking are, the molecule is the same as the molecule that we make in our body. So if we take estradiol, we're taking, that looks exactly the same as the 17 beta estradiol that we make in our body. Same with the progesterone. Micronized progesterone is exactly the same molecule as we make in our body. That's basically what bioidentical means. And that is available in many different forms. So there's tablets and there's sprays and there's gels and there's patches and there's creams, and they're all FDA approved at CVS and relatively inexpensive. So people need to make sure they're not hoodwinked into buying an expensive compounded product that they don't need, because that exact same product is available at their local pharmacy with GoodRx for $12. Right? So that's the first thing that we need to understand. People use that term bioidentical incorrectly. So when we talk about hormone therapy, we could be talking about that estradiol, patch, cream, spray, pellet, right? That's all basically the same estradiol. Progesterone, micronized progesterone, which is the same as we make in our body. And then there are these other forms that are different than we make in our body. And the birth control is one of them. And in combined contraception, so things like Yasmin and Sprintec and all of those, they contain ethinyl estradiol. So it's a form of estradiol that's synthetic, that doesn't look exactly the same as our own estradiol molecule. It looks similar, but not exactly the same. Why is that important? Because it doesn't fit very well into all our receptors. So it's really good at suppressing ovulation, but not really good at crossing the blood-brain barrier and having the effect on our anxiety and our mood and everything else that we get from the estradiol that we make in our body, right? So it doesn't have exactly the same effect on our body. So birth control is ethinyl estradiol and a progestin. So a progestin is a molecule like progesterone that has a similar effect on the uterine lining that is synthetic. And there are many forms of progestin. There are tablet forms, IUD, the Nexplanon, the Depo shot. There are many forms of progestins that are used as contraception. Now, when we make decisions about how we're going to treat somebody and what we're going to choose, the first question we're going to ask is, do you need contraception? Because that's going to help us decide which side we go to, right? Do you need contraception? That's the first question. Second of all, are periods a real problem? Are you having really, really heavy periods? Are they really irregular? Because these forms that are synthetic generally are better at controlling periods than these forms. So when you start to build a picture of the patient, do you need contraception? What are your periods like? What is your family history? Then you can start to kind of put together a treatment plan that in some cases is going to help their symptoms, whatever their symptoms are. And usually that's with your bioidentical hormone. And maybe you're going to pair that, do only bioidentical, but maybe that person needs contraception. So you're going to take that estradiol and maybe add it with an IUD, right? And marry the two and create this perfect secret sauce for that person that's going to give them a hormone replacement that they need to help with their symptoms, but the contraception that they need too. So hormone therapy, there are many, many, many different forms, many ways you can combine it. There's no one way that's correct.
Got it. That was like a really great explanation, because I've never really realized the differences between the two. And the way you put it earlier, talking about like women in perimenopause still have the ability to get pregnant. So like, yeah, contraception is a big deal if they don't want to have a baby 20 years later.
Yes. Yeah.
Amazing.
And it's a conversation that needs to be had, and it happens. People get pregnant.
And that's when you get the oopsie babies.
Yes.
When women start HRT or other interventions, like what's realistic? Because you mentioned feeling automatic results, like feeling great overnight. Like What's realistic in terms of like mood changes and energy and like symptom relief? Is it always immediate for everybody?
So it depends on the symptom. I generally find things like hot flashes are better, are, improved very quickly, within weeks. I generally find that sleep improves pretty quickly within weeks. Mood can be a little bit of a slower burn, right? Maybe it will take a couple of months. And also don't forget that we have to do some dose, we have to pick a dose. And I generally start on the lower side and then titrate up. So you might have some women that are great on the low dose, but then a lot of women need a higher dose. So it takes a while to kind of titrate the dose to find, the best dose for that person that's going to control their symptoms. But I would say things like hot flashes, sleep, we generally get under control pretty quickly. Mood, libido is kind of a slower burn.
Okay. So realistic timelines, everybody. Like there's it's not always a quick fix for
It's not
everything.
always, and
Yeah.
also it's not, sometimes you just have to find, I do a lot of pivoting. We pivot.
Yeah.
We start something and we pivot and we try
Yeah.
something else, or we change a dose, or and that's what part of the reason I can do my medicine the way, because you can't do that in conventional healthcare, right? You can't, like, I'm on the portal right now and a patient could message me and I could change her therapy right now at
Yeah.
7 p.m. And, if I had 2,000 patients, I can't do that.
No. So concierge medicine is definitely where it's at if you are able to, right? Like not it's not an option for everybody, but you do get that direct one-on-one care and outside hours. So that is awesome that you're able to provide that. As women are kind of learning and listening to this podcast, and maybe they're in their like years of being able to have a kid, maybe they're in premenopause. What's one thing you want women to unlearn today about that period of life? Because it's dreaded. Like me, I'm like I hear all these things and I'm like, oh gosh, like I have to look forward to that. But what's something that you want people to unlearn about it? Is it scary? Like does it have to be scary? Like cuz you're making it seem like you can thrive, right? Like it doesn't have to be this scary thing.
I mean, I have become like the best version of myself in, in perimenopause, treated. I never thought I would own my own business and, have a social media following and be, just doing all these amazing things, and my brain works, and I feel empowered. So I think, people have this idea that getting older is somehow the end of something, and I really think it's a new beginning, because when you go through perimenopause, one of the things that you lose is caring about what anybody else thinks, and it's
Mhm.
really like freeing and wonderful. So
Yeah.
when you pair that with a woman that has, that like feels good now, and can sleep and her brain works and she doesn't care what anybody thinks, you're up
You're
against somebody pretty
unbothered.
powerful.
Yeah. I
Yeah.
love that. That's a great perspective because some people just like really need to hear that. Like
Yeah.
it's not always doom and gloom.
No, not at all. And it's just, and again, people have this, you're making it sound like I'm not. I just want to make sure, I've done some family medicine. I've been in medicine. I started medicine into the year 2000, and
Mhm.
I've cared for a lot of people at the end of their life. I did a lot of palliative care and elderly care medicine and hospice. And I can tell you that, it's not great. It's, the end of a woman's life generally is not great. It's often a fracture. It's often a slow deterioration with loss of independence, chronic pain, and misery. And all I'm saying is we have tools that can reduce the risk of that, so that you have your independence and your vitality for as long as possible. I'm not trying to say that you should live longer than you do. I'm not talking about living to 120. I'm talking about living the same number of years that you
But
were going to live
thriving.
to begin with, but thriving.
There we go. I love that. Well, last question here. What's one piece of advice or a small blueprint that you were told to follow, maybe growing up? It sounds like you lived internationally before you moved to the States. What was something that you learned growing up that you've since thrown out? Like you're like, I'm not following that. And what did you replace it with?
Skinny is healthy.
Hmm.
Something I have battled all my life and continue to battle. This real deep, deep, deep core held belief that skinny is better, or, it's good. Being skinny is good. And a lot of women my age grew up with that as well, and older than us.
Yes.
And we've spent a lot of time battling our bodies and treating our body like an adversary. And one thing that starting perimenopause, going into perimenopause taught me was that I was treating my body as an adversary. I wasn't going to survive that in perimenopause. You know, when I had my hormones on board, I was doing okay. I could survive, you know, what was essentially me mistreating my body. But in perimenopause, my body was like, absolutely not. We are not doing this. And I had to unlearn and learn what I needed to give my body to be kind and gracious and love my body so that it could give me back what I needed it to, because it was failing because of my age and my perimenopause, but also because I was mistreating it.
Yeah. You weren't doing all the things that you now know and learned.
Yeah, I was
And
doing the opposite.
yeah.
I was, you know, doing cardio like a bunny. I was, you know, not eating. I was, you know, because skinny.
Yeah. Everybody's after that
Yeah.
feeling
And
of
people say
skinny.
to me, you know, sometimes, and it's always followed by tears. You know, I have women, you know, in my office, and they'll say, I just want to be thin. I know that I shouldn't say that, but I want to be thin. And it's tragic and sad that, you know, deep down inside they have this core belief. And, you know, even though they know in their mind and in their, you know, their conscious mind that that's not what they need and not what they're teaching their daughters and not what, but that's what's deep inside them.
Something they're telling themselves every single day when they look at themselves. Absolutely. And that goes really deep. Like it's not
Yes.
just like, oh, how you feel about yourself, but it really affects like your confidence, like your esteem, the way you show up for your relationship, your kids, like, and it's like hard because you don't want to like give other people that energy, but like you are indirectly, like subconsciously, like the way you talk, the way you look, like the way you feel, like all of those things. So
Yeah.
that's good.
Yeah.
Well, thank
And
you.
it's so much work to
Yes,
think all those thoughts,
it
you know,
is. It's it's the mental load every day.
it's exhausting.
Every day.
Yeah.
Well, thank you so much for
You're
coming on this
welcome.
podcast today. This was an awesome conversation. And I know that we could just go off for probably like 5 more hours about this. There's so many different things. So maybe I'll have you back on in the future and we can talk about
I
something
love
else.
that.
But where can listeners find you and learn more about you and maybe even work with you?
Yeah, so I live in New Hampshire. My practice is in New Hampshire. I'm also licensed in Maine. So my practice is called Lifestyles by Noor, and so it's lifestylesbynoor.com, and you can find me there and you can book an appointment with me there. I'm also online, so I'm mostly on Instagram, and my handle is Ask Dr. Noor. So follow me, and you know, I try to interact and answer questions when I can, but I do put
Absolutely.
out a lot of content.
Amazing. I know. And I found you on Instagram and I'm like, oh, she would be perfect because you left the traditional system. So,
Having a rant about something.
of course, yeah. And that's what we do best because we have to rant for people to
Exactly.
listen to us.
Exactly.
Amazing. Well, thank you so much.
Thank you.
If you guys like this episode, don't forget to follow the Female Blueprint podcast and leave a 5-star review. It really helps me reach more women who need to hear these messages. And if someone popped into your mind while you were listening today, maybe a friend, a sister, a client, share this episode with them. You never know how much it might help them feel less alone or even be the nudge that they need to finally start rewriting the blueprint for their own life. Thank you for being here, thank you for listening, and thank you for being a part of this community. I'll see you in the next episode.